Hi everyone, I'm Ho, a final year medical student from the University of Edinburgh. Today I'll be presenting on the topic Automated Electronic Health Record Frailty Assessment for older cardiac patients. As we all know, frailty is an indicator of vulnerability and morbidity, which signify poorer prognosis for patients. Frailty is an increasingly hot topic as the population moves into an aging one. To this date, there have been so many tools and parameters to measure frailty, with the more common ones being CFS or Rockwood Clinical Frailty Scale. However, there is still no one gold standard tool which could help us and healthcare personnel to assess patients' frailty. Hence, this is why we have developed an automated frailty assessment tool called the CODAF score, which is short for Continuous Dynamic Evaluation of Frailty. The CODAF score uses data entered by nurses and healthcare support workers routinely when the patient are first admitted into the hospital. Such scores are like Waterloo scores, the MUST score, delirium screening, patient's walking stability, recent falls, and so on. The algorithm will be able to identify the deficit presented in these data and compute a score ranging from 0 to 1, with a higher score corresponding to more patient deficits. With the CODAF score in hand, we wanted to know how well does CODAF perform compared to commonly used clinical frailty assessment tool, in this case the CFS score, and what else can CODAF score tell us from its value. We conducted a retrospective observational cohort study, recording cardiac admissions across 3 acute hospitals in Edinburgh for patients over 70 years old between April 2016 to August 2020. From a study population of 2,406 patients, CODAF score could be generated in 90% of them. We were unable to compute the remaining 10%. This is because the tool has a floor effect built in, so it requires at least 50% of the data, which was not met in 10% of the cases. From a nested cohort of 318 patients, we manually reviewed their case note to calculate their CFS score. We found that CODAF score correlated moderately well with CFS. The distribution graph here shows that there are least patients in the highest CODAF score and most patients are in the lower CODAF score region. Based on this table, we divided patients into 4 different CODAF quartiles. The sex distribution across the quartiles are quite equal, and a general trend could be observed. As we move up the quartiles, patients' length of stay in the hospital, percentage of inpatient death, and death within 12 months increases significantly. Additionally, patients in the highest quartile are 3 times more at risk of death within 12 months compared to patients in the first quartile. Moving on to the nested cohort, the results follow the pattern from the main cohort. Similarly, as we move up the CODAF quartiles, the CFS, the number of comorbidities, the number of inpatient complications is sure to increase. And most importantly, more than 50% of patients in the 4th quartile requires physiotherapy input before they are able to be discharged home, compared to only 5% of the patients in the 1st quartile. This graph shows that increasing CODAF score is directly associated with increasing length of stay of patients in the hospital. The bar chart shows that 16% of patients from the highest CODAF quartile lost more than 90 days home time in the year after their discharge, compared to only 6% of them from the lowest 2 quartile. This line graph shows that increasing CODAF score is associated with increasing risk of death at 12 months. In conclusion, the CODAF score is an automated frailty assessment tool using existing electronic health record to identify high-risk patients. It has been shown to correlate moderately well with CFS, And higher score of it is also associated with increasing risk of inpatient complications, increasing need for therapy, and increased risk of death. With the use of an automated approach, we would be able to faster identify older patients at risk of harm and target earlier, more proactive geriatric care for the patients. This is the end of the presentation. Thanks for listening. And if you have any other questions, just contact me on my email address as listed below. I would like to thank the following people for making this project a successful one. I would not have made it without them. So thank you. And thanks for listening.